You're audible.
Controversies in COVID-19 is there. You know, the COVID-19 is almost 8 months old now, and it's gone around about 210 countries and more. And the more the countries, the more the opinions, the more the scientists, the doctors, the politicians, the media, the ordinary people, whoever, wherever, they all have an opinion. And since we have easy access now to social media, everybody is putting in his bit into the pool. And that has resulted in a lot of controversies. They're going this way, that way, fake news, steady news, etc. Everything is going on. So there are controversies in COVID-19, which is there. And today our panelists have Dr. Shawaranjan Pal, who's a medical specialist and rheumatologist, Dr. Kunal Sarkar, who needs little introduction, cardiac surgeon and vice chairman of the largest private COVID hospital in Calcutta, and Dr. Deeptendra Sarkar, who is a general surgeon and breast cancer specialist, and myself. Now, the whole thing is that apart from all these qualifications or the training or the practice or the years of experience, all of us are a little bit confused, and we see a lot of controversies, one going this way, the other way, that. So just to settle that and come to some sort of conclusion on these things, we are on these controversies in COVID-19. So over here, we are having the controversies. There's a lot of things we are discussing, and not only this, but a lot of it. So I won't go through the list just now, but we'll go through the next ones quickly. So the origin of the disease, this was the one we were really talking about. And we know that China claimed that a bat coronavirus named the RATG13 was similar to the SARS-CoV-2. And in 2013, that's 7 years ago, 6 miners contracted pneumonia, and Zheng Lishi, was a Chinese bat woman, went down, found out from the bat fecal sample virus, which was designated as the RABT-CoV. And this was partially sequenced. And then in 2020, this year, February 3rd, hardly about 6 months ago, there was a Nature article from the Wuhan Institute of Virology led by Zheng Lishi. And she stated that the coronavirus RATG13, known previously as the RABT-CoV, showed a 96.2% sequence identity with SARS-CoV. And therefore, they said that RATG13 is the closest relative, forming a distinct lineage from other coronaviruses and supporting China's claim that SARS-CoV-2, or the coronavirus, is naturally occurring. As a result, the conventional wisdom that the COVID-19 was a naturally occurring outbreak arose. Nearly all of it was based on the single scientific publication, surprisingly one of whose authors had earlier received a medal from the Chinese government in January 2020. But then it was found out that this RATG13 is not actually a virus, because no biological samples exist, but a sequence of a virus. And there were doubts now of the accuracy, and it was found the collection method was a problem. And therefore, in comparison to SARS-CoV-2, there was a lot of problems already in that. So then Dr. Li Meng Yan, a Chinese virologist and who was a whistleblower, implied in a detailed interview that the RATG13 may have been used to divert the world's attention away from the true source of the COVID-19 pandemic. And this was a novel coronavirus that originated in military laboratories overseen by the China's People's Liberation Army. And they said that the SARS-CoV-2 has two unique features. One is a receptor binding domain, RBD, which appears pre-adapted for human infection, but is structurally similar to the RBD of the pangolins, which you can see up there, the scaly anteaters. But there was a furin polybasic cleavage site, and that's important because this was the one which allows the COVID virus to cling onto the human cell and penetrate it. And that's how the pathogenicity and transmissibility are increased. But this polybasic cleavage site was not present in any closely related bat or pangolin coronaviruses. So the critical component of the COVID virus seem to be not there in either the bat or the pangolin coronavirus. And then a scientific study published in July 1, 2020, pretty early, pretty nearby, And they said there was something which was nearly identical to the two pangolin coronaviruses. And they suggested that a cross-species recombination event between bat and pangolin coronaviruses had occurred. But there was no evidence supporting a natural viral recombination between bat and pangolin coronaviruses, resulting in such an outcome. And the next thing that was important was that a scientific article published as recent as August 5 showed that the pangolin virus is completely exonerated. Pangolins could have acted as a natural intermediate host for a human infection is totally dismissed. So therefore, given the overwhelming scientific evidence, the only recombination event possible for the appearance of a pangolin-like RBD in SARS-CoV-2 would be one occurring artificially in a laboratory. So with this, my question to the panel, and they have all read about this and know about it. So is the COVID virus natural or laboratory manufacturing? Can I start off with Diptendra? Are you muted or unmuted? Have you unmuted?
Thank you, sir.
Okay.
Thank you, sir.
Okay.
Well, I would be tempted to believe that it is an artificially created virus. And having said that, I was going through the evidences. If you look at the evidences, the first person who talked that it is absolutely a synthetic virus was a gentleman called Tom Cotton, a Republican from the United States. He went on emphasizing that this is a synthetic virus. In March, Washington Times also came up with the story that it is same. But having said that, subsequently all the stories that came up from CNN, from Fox, from US intelligence on 30th April, again was against synthetic virus. Antonio Fauci on 4th May and Pentagon on 5th May retaliated the same fact that it is a non-synthetic, naturally originating virus. I went into the scientific literatures and the reviews, and there I got publications from Lancet, from Nature, and Science Direct, which comprised of a panel of 27 observers. They all concluded it is a natural occurring virus. Now the logic that they have put forward is that, and as I said, I'm completely unbiased, I'm just giving you evidence. Now the logic that they have given forward is that it is too perfect RBD on the spike protein to call it a synthetic ones. There are two domains. One is called the GLN493, which adapts to the ACE2 receptors, get fixed and goes inside. Similarly, there is another domain which is ASN501, which is absolutely not required. If somebody creates a synthetic virus, why on earth he would create something which is irrelevant, which is antagonistic to attachment? So this sequence, in one, it permits a human-to-human transmission. There is another sequence which doesn't permit. So this quite appears that it is possibly a natural one. The last point that I would like to make is that while people were looking at pangolin as the intermediate host, they found that the particular RBT conforms not only to pangolin, but a large group of intermediate hosts, except mice and rats. So pangolin was thought of as the only exclusive intermediate host, but later on they came out there will be around 80 to 20 possible intermediate hosts who could have got the disease from bat and mutated it and therefore have transmitted to human, and the change in the spike protein made it possible for human-to-human transmission. So I would lay my case, my lord, on the side that evidences speaks against a synthetic virus. But all of us would like to prove it a synthetic virus. That makes life easier for us. But evidences are against it.
Yeah. So Kunal, your opinion on this?
Rajitha, thank you. I think, Diptendra has been so thorough as ever. But me being very thin, because I can count, I don't need the fingers of one hand to count the number of virology classes I had attended in those good old days. And I'm paying the penalty for that ever since. But I really think, what happened, Diptendra's scientific summary has been very, very thorough. But what really, apart from the data, Indrajitha, that you presented, it has been the fishy behavior of the Chinese and the Chinese scientific community around that time, because the time we are talking about now is the end of November through December into first week of January. So come the first week of January, I think it was 7th or 8th of January 2020, either 7th or 8th, when the first sort of definitive virological sequencing was announced. It was announced once from Wuhan, it was announced once from Shanghai, and I think right about the same time, the University of Bangkok also confirmed the virological sequence. But there was a lot of hanky-panky happening before that, because it is believed that way through December, the two labs which were working in Wuhan, either they already had the virus sequence worked out, or they had worked it out secondary to all these funny fevers happening, and some of the records were actually destroyed. The research that locally happened in the Wuhan lab was actually destroyed. And this is the press report that came out in Global Times in China around the first week of January. Wall Street Journal is the first international journal to have published this story, and that reporter was kicked out of China first. So, first of all, yes, the core science apart. Now, whether it was not a matter of science, but they were feeling unsure of themselves as to how to present this data to the world, there was a lot of shifty behavior on the part of the Chinese, and it is believed that some good amount of sequencing work actually had already happened in December, which was never shown to the world. That is one thing, that is what I think sort of gives fuel to the conspiracy theory. And around this period of time that we are discussing, probably whenever we discuss corona, like you discuss Indian independence, the martyrs come in. The corona martyrs, Dr. I think it was I. Fen of Wuhan, who at that point working in the Wuhan A&E department, emergency department, you mentioned the whistleblower. She is called the whistle giver. She is the one who first of all unearthed the whistle and told the world that something is funny happening here in the last week of December. And that was taken by Dr. Li Wang, the Janwin Liang, the ophthalmologist, who actually wrote those 4 or 5 lines in the social media, and he had to pay his price for that. So I think the science is there, but what really makes the atmosphere a little bit murky is the happenings from the first couple of weeks of December, where there is some suspicion that the Wuhan lab had already worked it out, and the Communist Party had suppressed it. If you have read the criticism that Xi Jinping is facing now from this woman called Zhai Hia. So Zhai Hia, who's criticizing Xi Jinping on the ground, that when he met the Chinese Politburo, the Communist Party Politburo, he had actually suppressed some data which he should have come up with. So a lot of funny things were happening, in the end of December. The science is there, but whether it was their indecisiveness or whether they were hiding something, time will tell.
Yes, I think, Kunal, that's a fair assessment in the fact that the Chinese didn't behave openly. They sort of behaved as if they had something to hide. Shamor, your take on this, natural or laboratory manufacture?
Actually, basically, there was a suspicion of suppression of data, and there were some inconsistencies in the findings, like the absence of a live virus akin to this, and can you hear me?
Yes, we can hear.
Absence of a live virus akin to this structure, and the absence of the structure of the virus which is consistent with the existing virus and its absence in the pangolins and these things and suppression, so much suppression of data, these rose some index of high index of suspicion. But this has not been corroborated. This has not been corroborated by any uh, medical literature. However, I think the work should go on because today we are really facing a threat of biological terrorism everywhere with the incidence of plague somewhere, the incidence of other some diseases which are refractory to treatment. Every day in the news we get incidents of some new news about bioterrorism. So I think we should be guarded in this, but time is not appropriate to condemn them and tell them that you have done this in the laboratory. I personally feel the evidence is tilted towards bioterrorism. This is my take on the matter.
Yes.
Sir, can I make a point, sir?
Yes.
Yes. Go ahead, Jitendra.
Now, the US intelligence report came up only a couple of days back. They have described it as a Chernobyl phenomenon. I mean, what happened initially was there was a large number of pneumonia cases, and the local authorities in Wuhan thought they will be able to contain it, and they unnecessarily delayed the reporting. That's what actually happened. Because if you look at what happened to the world on the same time, on 6th January, the genetic sequencing is done. 7th January, it is put up for genetic sequencing in the WHO site. On 10th January, 4 major companies applied for vaccine when it was only 500 cases in Wuhan. I couldn't explain why 4 companies, and this guy, I mean, Donald Trump tells that he didn't know. But if you look at the files, you'll understand on 4th of February, there was a clear-cut direction in an open interview in CNN. The intelligent guys tell that there was a direction to Donald Trump that something worse is coming. And Antonio Fauci on 21st of February suggested that there should be a lockdown. On 2 days next, he was in a tour to India. And the first trial, the phase 1 trial on 13th of March started in 3 companies when the lockdown was not implemented. So here we found a large group of people who are investing in billions for creating a vaccine, whereas the politicians are in a complacency mode. They're trying to look at that nothing is going to happen. So these are contradictory behaviors which remains unexplained.
Very true, very true. Actually.
Yes, I think that is a great summing up. And I deliberately didn't put the laboratory manufactured as deliberate or accidental. So we will not know the whole thing of it, but suffice that court cases have been launched, and somewhere or the other, when everything settles down, I think there'll be a great inquiry on what happened actually. And maybe, just maybe, we will know the truth, or maybe it'll remain one of the biggest secrets like
If I just make a relevant point over here.
Yes, Kunal.
Before you go on to then why all this becomes important is that the first reporting from Wuhan, as Jitendra was saying, they first said they had 40 cases. Then in a few days, they said they had 400 cases. But as we approach in the middle of January, the important thing is that we were approaching the Chinese Lunar New Year. The Lunar New Year festivities actually happened, where they let the cat out of the bag was the time between 15th of 20, whilst they were, all this shiftiness was going around to declare or not to declare what was happening in the Communist Party, but they led themselves into the Chinese Lunar New Year, and that is supposed to be the biggest flux of humanity that moves around at that time of the year. So 2 things happened, which is in that 2 weeks, like India's mistake of letting 6 lakh passengers into India, 20 lakh passengers into India, and somehow, mysteriously, in the last 3 weeks, the foreign travel out of Wuhan was calculated as something like 10 lakh passengers go out of Wuhan in some 3 weeks' time. So one is the people, the flight of people outside Wuhan, the international links. And the second thing was, as far as China was concerned, that they go perilously close to the Chinese New Year, I think, which was 18th to 20th January, and then hell breaks loose after that.
Yeah, so there are a lot of things which has to be found out later on. But at the present moment, what we are facing is that the virus is on us.
Yes.
And we can talk about the origins of it till the moon turns blue. But the fact is that what has happened, and now we have to face the virus itself. So to face the virus itself, we have to look into the testing. And the testing that we have here is the RT-PCR, the NAT test, the rapid antigen test, the rapid antibody test. And the numbers that we are getting nowadays as testing is antibody test plus rapid antigen test plus RT-PCR. And over here, there is an issue which is needs to be discussed. So one of the things that is happening all over the country is the blood antibody tests and the sewerage tests. Now the blood antibody test by itself shows that what you will generate is whether there has been past infection. And what is the importance of this would probably be in a sero survey by the antibody test, but we are not sure what's going to happen to that. So Ditendra, you're a great believer in the antibody tests. Why?
Actually, sir, antibody test has its own role. Basically, CDC have divided the test into three: the diagnostic test, the screening test, and the surveillance test. As antibody test actually is the best possible surveillance test. It can be used in frontline workers to screen them out, but as I said, the best way is its place is in surveillance. Now, if you look at NHS throughout the pandemic and the lockdown period has been publishing the weekly serosurvey report. And based on that, they were able to set their strategies. Somehow, I failed to understand, this is a closed forum, somehow I failed to understand why the government throughout India did not go into a continuous weekly serosurveillance report of different parts of India. That would have made us actually navigate. Instead of incidence-based closing and containment, it could have been a community-based containment based on the serosurvey reports. So serosurvey reports would have navigated us about the interzonal movement. That never happened. We had in last 5 months, 3 or 4 sporadic serosurvey reports coming up. But serosurvey report is the only way of screening the population and putting the population to surveillance. But its role has not been played the way it should have been.
Absolutely, agreed, absolutely. The serosurvey role of the rapid antibody test is huge. So now they are bringing out the sewerage tests, which I've just given over here. Kunal, are you a great fan of the blood antibody tests as such?
No, I think, I think the important thing is that, just to amplify or to continue from what Ditendra said, that you see in epidemiology, historical epidemiology, whatever has happened is, people always studied pandemics on hindsight. But what we are doing today in 2020 is trying to study a pandemic in real time, as it is happening. And if you want to study a pandemic in real time, then obviously we have to fall upon 2 sets of things. One is a mapping, which gives us a profile. Where is it? What is the population predominance? How is it infective? So profiling or mapping of a pandemic obviously is obtained through antibody tests, but antibody tests had to be used far more thoroughly, far more exhaustively, and far more strategically. Because we seem to just have a smattering of a few antibody tests here and there. And the other importance is that through proper usage of antibody tests would have made exercises like unlocking. Like today, every 6 hours we are debating, when should metro rail start? When should the suburban rail start? When should children go back to schools and colleges? You see, every exercise has what is called an infectivity trade-off. So it's like a quantum. You exchange one packet for the other. So instead of deciding these very important things on which the livelihood of people hinges. So this is a kind of data which done properly and which done far more exhaustively would have helped us to make these decision makings. That how do you take these steps towards unlocking, transportation, resumption of school, colleges, investigation. So therein is the role of antibody tests. Previously, what we are scared of travel today. Historically, how did pandemic spread? There was no travel, in the 5,000 years ago. All the pandemics spread through war. The first pandemic that has ever been recorded is during the Peloponnesian War between, Sparta and Greece. So armies used to march, they used to fight, kill people, and the zoonotic diseases used to march along with them as well. And at the end of the day, people would die either killed by the soldiers or by the infective organisms, and that would be the end of a military campaign. So today, I think antibody tests have to be done far more systematically. The question actually remains, I think what you have raised, a very important question is the accuracy. Because like in Delhi, today we believe 70% of the tests being done in Delhi are rapid antigen tests. Maharashtra is the real, the seventh, eighth and ninth wonder of the world added together. It is the only part of the world which is vomiting cases for 5 months incessantly, right? It's like a diarrhea of COVID cases, and I think they are refusing to stop. And in Maharashtra, the health infrastructure is so hopeless.
Kunal, we'll come to all that.
So my last, I'll just end up by saying is the real confusion will come in the diagnostic arena. Not in the mapping arena, we are insufficient, but at least something is being done. And in the diagnostic arena, when we mix up and we kind of confuse the figures, that how many are RT-PCR and how many are antigen tests, then I think there will be a little bit of indecisiveness in interpretation of that data.
Yeah, I think we'll come to that. Shamor, your idea of the blood antibody test, I think Dipton has a very valid point that it should have been done systematically from a long time to detect by the serosurvey what is the actual incidence. Your take on that?
There are two parts to this question. Regarding the diagnostic portion, definitely no single test is absolutely diagnostic, but for a community screening, rapid antigen test can be done, but it has its fallacies. RT-PCR, NAT test is the gold standard of treatment, gold standard of diagnosis. However, serosurveillance, and I'm telling you, this has been advised by the expert epidemiologists. It was advised to the government of India sometime in April. I had talks to some very famed epidemiologists, and they said there was a plan to induct these antibody tests in the population at large. And that would be actually giving a true picture of the spread of the epidemic and how our strategies should be to contain the spread of the virus. Because if we have a situation, say, with a very high incidence of antibody titers in the population, then we'll definitely know that, say, 50% of our population or 30% of our population are having antibody titers. Then they have already had the infection, which was not severe, and then we can make our plans accordingly.
So the testing of the RT-PCR has all of these fallacies: the false negative, the false positive, what is known as the persistent positive, what is known as the recurrence, and finally the cost of the RT-PCR test. And one of the things that comes in a recurring thing is the cost, if it can be made free. Anyway, the false negative and all that is a huge problem. The false positives, I don't know how that happens. And the persistent positive and the recurrence, we'll just deal with it a little more. But you must remember what Shravan was saying, and this came out in the NEJ. There's absolute certainty in diagnosis is unattainable. No matter how much information we gather, how many observations we make, or how many tests we perform. So if that is so, every test that we are doing will have its small fallacies. Now, so why are there false negatives in RT-PCR tests? And this time we start with Shomor. Why are there false negative in RT-PCR tests?
Basically, it depends on the timing the tests are done. If it is done too early, then we tend to miss the tests. It should ideally be done in the 5th to 8th days of the illness or post-exposure. If it is into that period, the chances of getting positive test will be about 70% around. Whereas if we do it in the first 4 to 8 days, first 4 days, at least there will be very high incidence, about 50% incidence of false negative tests. And if it is done later than 8 days, into the 9th, 10th or 11th day, then the chances of RT-PCR from the nasopharyngeal swab will be negative. We can get it from secretions lower down, like the bronchoalveolar lavage collection or the sputum collection. We can get it from there. So it depends on the time of the illness when we conduct the test. Another thing can be the collection of swabs is also a problem, because it is not always done by the persons well trained in it. And particularly one thing should be discouraged: the home collection should be discouraged, and it should be done by very competent and trained individuals only.
Yeah.
So if it is done at the proper time,
yes,
about 70% yield is there compared to any other test, single test like rapid antigen test or whatever. It is the gold standard of therapy. And if we are strictly confident, we are severely confident, we are absolutely sure of the clinical diagnosis, the test should be repeated.
I think that's what comes on the test. 4 days after infection, 67% are negative. Average incubation period is 5 days for the disease. So if test symptoms are started, after that, 38% negative, and test 3 days after the symptoms is 20% negative. But we come now to the next question, Ditendra, the persistent positives. So the viral RNA can be persistently detected by PCR in respiratory tract samples after clinical recovery, sometimes for weeks onwards. And let me tell you a little story of our doctor father, the son was also a doctor. So Dr. Father was tested positive, went to a hospital, and his insistence was that he be released after he was negative. And the negative wasn't happening. So they discharged him in the positive state, and he continued to be positive for a month after that. So Ditendra, what is the persistent positives? Is there any logical explanation, or what happens?
As you rightly said, sir, I mean, if you are just looking at the RNA, the virus is dead. So that's the easiest explanation, and that is the reason CDC and later on WHO as well as ICMR has shifted from test-based to time-based. But I would like to make a point about the false positive. Why a significant segment or proportion of patients are having false positive. And today only I happened to talk with one of the journalists who has spent almost 18 days in his home. And he gave me a call that he did IgG twice, and every time it came out to be only 0.1. So he has started believing his initial was actually false positive. There are two reasons. Number one, I was told by my virologist friend in IPGMR SSK, the first test that runs is a pan-coronas run. So it would actually test all the 6 stains. And if it is positive, they would run an COVID-19 specific, that's the second run. So what was happening once many of the laboratories would take it, hypothetically, they would run the first part and would not run into the second one. So the false positive was because of non-COVID-19 corona strain. That is one reason. The second reason, the different companies, they have different threshold of viral level at which the positivity comes. So there are some companies who try to increase the positivity yield, and so they lowered the threshold. So a small amount of contamination in the lab would give rise to a false positive report. So if you look at companies like Abbott, their threshold is only 100. So even if there is some contamination on the place they are doing it, it will lead to a false positive. So these are the two specific reasons why false positivity is coming up. It's a genuine problem. We have had so many patients who have been tested false positive. And therefore, it also created confusion, because initially what was done was in the government sector, if somebody tested positive in the pan-corona strain, they were transferred. In the evening, the report came, it is negative. So people started believing that there is a manipulation in the test. It's not manipulation. The first run is a pan-corona strain, which can be positive. In the second run, it can come out to be negative. So that's what happened. And many of the private small lab would skip the second one. And we know of a lab where this question came up. They were reporting large number of positives. So that's the explanation.
I think that's an excellent explanation there from Ditendra. And what we find that we were under the impression in initial stages that a positive means a positive. If you have seen a particular sequence and the DNA and the PCR test shows that it's a positive is a positive. A negative can be a negative, but a positive is a positive. Now we find the terms like false positives coming in.
Yeah.
So this one for Kunal, the recurrent positives. So in some people after tests negative by the PCR in 2 consecutive samples, they're released, they're doing well. And then later, within a month or so, their samples turn positive.
Actually, I think this probably is the phenomenon which has been explained by this thing of the dead virus and stuff like that. That that people are picking up the viral remnants from the specimen. There was a lot of concern from North Bengal and other areas that whether people are getting reinfected and all these kind of issues. But I think that has by and large been laid to rest. So I think the dead virus phenomenon, some kind of a phenomenon is there. I would allow me, Indrajit, to introduce 2 other perspectives when we discuss testing here is that currently, you haven't raised this question, I'll just raise it and seek others' opinion as well. That at a time when India was doing 2 lakh tests per day, the percentage of antigen testing was about less than 10%. Today, when we are doing 8 lakh to 9 lakh tests per day, the percentage of antigen testing has gone up to about 50%. More than half of the tests done right now, every day nationwide, is antigen testing. Fair enough, whatever be the reason. But antigen tests, number one, have a very high threshold.
If I might just interrupt for a moment, this is something we'll discuss in the next slide.
Oh, you will? Okay, fair enough.
It is there.
I'll wait till the next.
Yes.
Okay.
I know that's a very important point that you made. Now, the whole thing, what happens in these persistent positives and the recurrent positives, from ICMR and from everybody, even the WHO, they have come out with this concept that these are not infective.
Yes, that's right.
So that if you have a persistent positive or recurrent positive, they are not infective. So that is a good thing. So we may worry about the thing, but in terms, it is not infective. Again, I come to the CT value of the RT-PCR test, which have been said by no other person than the ex-IMA president in various video interviews. The CT value is something which we are looking at. So you see over here, the CT value by itself is called the cyclic threshold value, which indicates the viral load. And at some time, it was said that if your CT value is, say, less than 32 or more than 32, the cutoff value. So more than 32 shows less viral load. And the question that was raised now, should in every RT-PCR, should you attach the CT value? And this is what the Karnataka government wanted to do and wrote to ICMR on this. So the ICMR replied, said no, not advisable and is statistically flawed. And they said that there's no reliable data to show link between severity, infectivity, and CT value. And on more than that, they said that mild symptomatic cases have similar CT values to severe cases. And it depends on the collection, testing skills, calibrated equipment, pipettes, etc. And that was a whole issue. But the CT value is something which has been discussed a lot, debated about, but according to the ICMR, it is not reliable. So CT values Shamor, your idea, should one show the CT value? Will it give an impression that these are the cases which needs to be looked after properly if they have a low CT value?
As far as the literature, I have gone across the international literature, they have attached much value to the CT value because a higher CT value means basically definitely less viral load, and there is no need for doing repeat or follow-up tests for viral load. That is not necessary. One single test is enough, and then we follow the guidelines of the ICMR. But on the first testing, if we see a CT value which is low, say around 16 or 17, which is a high viral load, then we can be careful about managing that patient with early intervention if required, rather than a patient who has a high value like 32, 33. In that patient, we can safely keep the patient at home. That is my carry. Why the Karnataka government and the ICMR has objected with this is not clear to me, because all the international references have suggested CT value relation to viral load and the severity of the disease. So we should be careful which cases can be severe. We can keep them in observation or admit them in hospitals at the earliest.
Ditendra, anything on the CT value? Should we ask our patients when they do a RT-PCR to give the...
Yes, sir. I completely agree with Dr. Pal that yes, it would have helped us in re-stratification. I mean, we can be very sure if somebody, even if there is comorbidities with a low viral load, it would have spared them with a hospital admission. That is one side. But I think the main reason why ICMR would have not agreed to the government of Karnataka would be the huge amount of volume testing. I mean, as I know, most of the centers who are testing 1,000 plus tests every day, they are doing it on a pool sera, just to reduce the load. So if you're doing it in pool sera, then going for the second time and trying to find out what is the CT value doesn't make any sense. So it must be the bulk and the volume of testing which would make it difficult to report the CT value, so they have not got into the confusion. That's my understanding.
Okay, so Kunal, I won't ask you on the CT value now, because...
Can I make just a quick intervention on the CT value? Look, I'm not a lab person. Probably Shamodda, Ditendra knows a bit better. But somebody was telling me the other day that there were some of the machines that were installed in the beginning, probably in the beginning of the screening cycle, etc., which probably are not able to give it. That may be one of the reasons. I'm not sure. Second reason is that, knowing CT value would have another derivative, because it is going around in the sort of colloquial impressionism that many doctors tend to get severe disease simply because their viral load initially is high, especially people working in critical care, etc. So that could have given us some insight into the disease before. But one thing I will just tell Ditendra is, I know a lot of the individual labs who are doing these testing, I think you have to have specific permission to do pool testing. Because if you don't have permission to do pool testing, no matter how many samples you do, you cannot do pool testing, because one particular lab in Calcutta which did it ran into problems. So some labs were trying to do it to save time and resources. But that is not, I don't think that is allowed by ICMR. You have to take permission that, these 1,000 samples, I do pool testing. I don't think that is allowed. ICMR gets very cross if you do pool testing without notification.
Quote unquote, that's the famous Indian honesty.
Yes. Yeah, they got very annoyed with many labs who did pool testing.
Why are we testing so little compared to other countries like this? I understand the other countries have smaller populations, so the numbers of tests are much less, and a bigger one. But even if you compare it with the United States, 314 and we are 18, and this is 16th August.
This is March data.
Oh, this is March data, 16.3, no? Yeah. Anyway. Yeah, right. This is March data, right? 16.3. So we were testing much less, and we haven't really gone up the ladder that much, but we are testing much, much, much more. And so the question of testing, or whether the testing should be made free, is something which comes on from here. Would a thing, so would a whole thing of free testing done something more for us? So now we look to the rapid tests. So that's the reason why we wanted to do more tests, that we turned to the rapid tests. And the rapid tests by Oxford group had 98% accuracy, unconfirmed. Worldwide, 80% accuracy. And ICMR announced on 4th August that up to 30% of the total tests conducted in the country were antigen tests. And if we look at it, it's rapid, cheaper, but it's inadequate, as we have already said. So we isolate the antigens unique to the virus. Accuracy sometimes is lower than 50%, but the results are out in 20 minutes. So it's easier for surgeons that in the morning they do the test and probably get on with it in a much easier frame of mind. Now it shows that you're currently infected, and ICMR has improved 3 antigen tests from South Korea, Belgium, and India. And the ICMR AIM study on 1 says the accuracy is 50 to 84%. And the ICMR guidelines is that negative antigen should get an RT-PCR test done. And that's a guideline. Whether that will be followed, I don't know. But if you look at Delhi, what's happened there, and this was the thing that Kunal was saying about, Delhi on the 29th June, the black ones are the antigen tests, and the RT-PCR are the red ones. And on 29th June to 27th July, in the space of 1 month, you see how the black lines are going up. People are doing far, far more antigen tests. So that's how the figures are going up of testing. And if you again look at it in another aspect, less than 1% of those who tested negative in an antigen test went on to have a PCR test. And 18% of those who did tested positive. So the authorities have now asked testing centers to conduct more PCR tests. And the Delhi High Court said that the antigen test should be used only in hotspots and healthcare settings. So Karnataka started using antigen tests in July, aiming for 35,000 a day. And the number of antigen tests have been going down, and the number of PCRs are coming down. The antigen tests are going up, and the number of PCR tests are going down. So Karnataka, last week of July, 38% of those who initially tested negative but had symptoms and then took a PCR test came out positive. Telangana has government facilities for 320 government facilities for the antigen tests and only 31 government and private labs for the rapid tests, for the PCR tests. So, but 320 government facilities for the rapid tests. And Maharashtra, and this was the key thing, Kunal's adjectives were hilarious, but he reported that 65% of those who had symptoms of COVID-19 tested negative in the antigen test, but went on to be positive in a PCR test. So, switch to rapid antigen testing may satisfy performance targets and meet public demand for more, and runs a real risk of not revealing the true extent of the outbreak, unless it's backed by continuous PCR testing. And so the number of positive tests may be more than what is being shown now. The number of tests increase, and since if the number of tests increase, then our fatality rate goes down. So that is something to look at. And now, what did we do in Bengal? On the 7th of July, we had 98 people, all frontline health workers, took the rapid test. 4 tested positive, confirmed by RT-PCR. 94 tested negative. And the negative results, especially in highly suspected cases, need an RT-PCR test for the gold standard. And we all know Bhaskar, who's a very good infectious disease specialist. Then comes this issue. What is the more very worrying? And hundreds are queuing up at medicine shops and medical outlets to buy rapid antigen test kits, self-testing at home. At Shiliguri, these kits were being sold for 500 rupees in the trade. And these are not like pregnancy kits or blood sugar testing devices. So antigen tests must be used with RT-PCR tests to be sure. And that's what our good friend Shumit Sengupta said, the pulmonologist. But Bengal is now doing the rapid antigen test initially at mainly in the hotspots and the containment zones. So your views on the antigen test, I think we've all made ourselves clear on the thing of it. But the problem is the antigen test is a rapid test. It's not a delayed test. So it gives some indication of what is going on, but it is not an accurate indication.
Sir, can I make a point on this?
Yes, at this point you make a point and then we'll come to this question which is on the screen.
Now, when rapid antigen test was allowed by CDC, they explicitly mentioned it to be a point of care testing. That means somebody who has been having a severe acute respiratory illness arrives at a hospital, in 30 minutes you diagnose that this is possibly COVID. And then you admit and you can start treatment on lines of COVID. So it has its role as a point of care. I mean, somebody who comes, but it has been used generously as a screening test. The purpose of rapid antigen test was never to have a screening test in the whole population, but it has been widely used by most of the centers. That's unfortunate, but it has its role because it has got very high specificity, very high false negative rates. So if somebody is positive, that means he is true positive. So if somebody arrives at MR Bangur in 30 minutes with a respiratory distress, you know this guy is suffering from COVID. Previously, if you had to believe in RT-PCR, then the patient would have waited for 1.5 days to get an RT-PCR test. So we have converted a point of care test for diagnosis to a general use. That's unfortunate, but the test should not be blamed for that.
I think that's a valid point. It has its place. But not fill up numbers.
Can I make a point here?
Absolutely. It's yours, and after that,
a couple of points. First of all, as far as the why were we initially testing little, there are two perspectives. One is if somebody mute their mics, somebody is ordering dinner in the background. That makes me feel hungry. So
I'm not sure who it is, but anyway.
Fair enough. So I think one thing is, probably if my impression is that setting up an RT-PCR lab, getting out into the districts, out of the city, etc., is not an easy job in our country. So I think that has got severe infrastructural and manpower limitations. And that is where so many people are, so many states can go that much and not beyond. So every state you look at in India can take a few steps and get stuck. Second point is, just a point of hilarity that you mentioned Telangana. Hyderabad actually had the lowest testing record of any city in the world. Actually, way into May or June, there were a few days when Hyderabad had not tested anything at all, right? So even if you went into dark, deep Africa of Livingstone, you couldn't find. Hyderabad probably wanted to diagnose COVID through horoscopes. I think they're very good at it over there. But they had the world record of any city in the world testing lower than that was not seen. The other question, which is, I think, a bit oblique but important, that question is, ICMR keeps a very tight tag on this RT-PCR labs and COVID testing, etc. Fair enough, they're very possessive about it. And in India, we are perhaps the only major country in the world which are scattered with diagnostic facilities, and 50% of them are not that bad. So we did not use our diagnostic capability potential in the private sector to use it. If you can do CEA antibodies, prostate-specific antigen, whatever, lipid profiles, why couldn't we not do it in the private sector? Because that was initially done under the premise of quality control. Fair enough. But now that we have mixed, milk and water together, and we are doing 60% of these tests or 80% of these tests being antigen tests anyway, I don't think that puritanic principle of tight control on RT-PCR holds anymore. So probably with some quality control, this restrictive possessiveness on RT-PCR tests should now be lifted to enable more labs to do it, because that may be one of the ways in the same price band, because otherwise, I think, that we have gone up to 8 lakhs, 9 lakhs, whatever, thanks to the addition of the antigen tests. And at what numbers testing should end? Testing should at least be escalated to the level that the test positivity rate comes below 5%. That should be a threshold in a country like ours, because now all India wise, I think we are somewhere one day between 9%, then in 11%. In Kolkata, in West Bengal, I think to yesterday's figures is somewhere around 8.9%. We had gone as high as 16%. So I think numbers should be escalated, preferably RT-PCR, till we get a test positivity rate of around 5%. But I am sure, no matter how much we shout at the top of our voices, there are serious infrastructural and manpower limitations to make RT-PCR possible primarily in the government sector. They should really now look to using the non-used capacity in the decent private sector labs a little bit more.
Shamor, your views? Antigen test, anything new to add, or will you talk about at what numbers will
Antigen test as a screening test, it is fine. And in cases, emergency situations, as Dr. Deeptendra has mentioned, that is fine. But one concept, even RT-PCR can be negative. So we treat in the clinical context. If we are clinically sure this patient is likely to be COVID in a situation of acute onset ARDS, in this scenario, we will treat it as ARDS, ARDS due to COVID-19. So that is accepted. So antigen testing can increase the numbers, but it will not contribute to treatment except in an emergency setting. So I think we have to depend on RT-PCR, and RT-PCR testing has to increase. How it will be increased? That is a very difficult public health problem. The government has to sort it out in conjunction with the private sector or whatever. And regarding the testing costs, I think the cost should come down. Cost should come down if it is more affordable. And because of the stigma attached to it, once a person tests positive, then his whole family is ostracized in the society. And so these are certain things why people don't want to. If we advise them to go in for, say, they will just isolate themselves, quarantine themselves, keep themselves quarantined, and then if majority of cases subside on their own. And that is how we are, I think, basically we are missing active cases which are asymptomatic or mildly symptomatic cases. If the cost of tests goes down, then more tests can be done, and I think we will get more sufficient data. And regarding the numbers, the WHO set a target of 140 per million, which we have now exceeded. As of date, we are doing 750 per million tests, and we propose to do 900 per million tests. That is 10 lakh, that is 1 million tests per day. So that is the goal. And about more than 50%, this shows 50%, I think more than 50%, maybe 70% are antigen tests, and the rest are others. In the cases where antigen test is negative and we have a high index of clinical suspicion, RT-PCR is mandatory. And RT-PCR test repetition after recovery of illness, I think, is superfluous. That is what the current medical literature suggests, because both ICMR and other international organizations say the repetition of test before discharging a patient or before continuation of therapy and other things, rehabilitation is not essential. And that leads to unnecessary confusion. Thereby, we can cut down on testing numbers, we can cut down on costs. That is my carry.
I'll just like a quick word from Ditendra on what he feels, when will the testing end?
I think the government should come out in the open about the serosurvey status of the country. We must know in which direction the country is going. Then only you would be able to come out with your next policy. I'm sure they know, but it's not in the public domain. So I don't know in which direction this pandemic is going. My only direction is from media, who would always tell the number is increasing, lafiye badche, but that doesn't give us any viewpoint of what's happening to the pandemic.
Correct. So we have serosurvey, sewage survey, mutation. I don't want to go into this right now. It's too okay. Let's turn to the therapy part of it, the hydroxychloroquine. So this was a paper which came out in the Archives of Pharmacological Research 2020, and said that considering their ocular, cardiac, and neurotoxicities, chloroquine and hydroxychloroquine should not be recommended as preventive drugs for the COVID-19 pandemic. 1st of August 2020. So that brings us to this, the Medica experience, the anecdotal experience. And Kunal, I want to start this off with you, because I was told that no patient or very few patients of rheumatoid arthritis on chloroquine got serious COVID-19 disease. And you have an experience in a hospital of over 2,000 cases. And you can read the other slides, the ICMR recommendations for chloroquine, etc. But that's an advisory they gave way back, and that which many have been following. But Kunal, is it true? It's anecdotal, I understand. But seriously, none of the, or very few of the rheumatoid arthritis who were on chloroquine, did they get serious COVID-19 disease? Kunal, you have to unmute yourself. I think you got muted, I think.
Yeah, I think, it is true that it is anecdotal. It is not completely unsubstantiated. I mean, even though we have a decent volume of this, of COVID cases, there is an impression amongst our clinicians that people who were on chloroquine long-standing for rheumatoid disease and maybe some other conditions, they did not really get clinically manifest as much. And by and large, because all of us to varying extents have been exposed in clinical situations. And even in that situation, we made a decision way back in February, at the beginning of March, that we put the entire clinical team on this the telltale doses of chloroquine, and we've kept as such. But I'm told, even by the medical team at the moment, that they have not really come across that many patients who've been on previous on chloroquine for rheumatoid disease come in with florid COVID symptoms. I think that impression still stands.
So these are the ICMR recommendations for chloroquine, which we all know about. And this is another trial of the hydroxychloroquine in post-exposure prophylaxis. So this was done by the NEJM in 2020 June. And they said that a randomized double-blind placebo-controlled trial across the United States and parts of Canada, they tested hydrochloroquine as post-operative prophylaxis. So they assigned participants to receive either placebo or hydrochloroquine, and they exposed them to persons who were in their families or who were exposed, and to others. Laboratory confirmed, whether they found laboratory confirmed COVID-19 or illness. So the high risk or moderate risk exposure, the high risk means that they wore only masks or no masks, and the moderate risk was the ones in which they, together with that, they wore face shields. Hydroxychloroquine did not prevent illness compatible with COVID-19 confirmed infection when used as post-exposure prophylaxis. I don't know the pre-exposure part of it, but that should not be there. Anyway, so hydroxychloroquine should be taken as prophylaxis. This is the question I put to the panel. So start off with Shamor.
Yes.
This is your pet topic.
Yes. Two things I will highlight. You had raised the patients on hydroxychloroquine, RA patients, rheumatoid patients on hydroxychloroquine, whether they had COVID-19. Actually, I have several patients on hydroxychloroquine, RA patients. Fortunately, maybe I haven't had an occurrence of COVID in any of my rheumatoid patients. That may be a mere coincidence, but I have got a sufficient number of flares in lupus patients on hydroxychloroquine. This kind I can tell you. So hydroxychloroquine is amply protective. I cannot share this fact. Secondly, regarding the pre-exposure prophylaxis as prescribed the ICMR, most of us doctors who work with patients, we are taking this in our country, and I find the incidence of COVID-19 in persons, in doctors or frontline workers who are already taking hydroxychloroquine in the prescribed doses. I have not come across any case. Of course, the limited number of persons that I know, vis-a-vis the patients, the doctors who are not taking hydroxychloroquine. This is definitely not a study. There is no double blinding, nothing. But I think, and this is the ICMR guidelines, and whole of India is following it. I think, at least for the medical professionals and the frontline workers, I would, as a first line, advocate it.
Kunal?
I think we're good, because maybe we are hanging on to straws, but fair enough. If it doesn't do good, go back to dear old Hippocrates and say, even if it does no good, it does no harm. So get on with it.
It is pre-exposure prophylaxis. It is not for treatment.
Yes, that's right.
Kunal, was there something in Medica in which a couple of your directors got this COVID-19? And
yes, one of them, no, two of them got COVID, and I confess, I think both of them were on prophylaxis.
Yeah. I will ask one question to all three of you, and be honest about it. Are you taking hydroxychloroquine?
I am.
I am.
I'm also.
I am.
And
Sir,
I think.
Sir, can I make a point on this?
Please, go ahead.
We are running this short trial at IPGMR, where we have put in those persons who are taking hydroxychloroquine. You can also, I will pass on the link, you can submit your data as well. And we have been able to initially analyze and find that those who are taking hydroxychloroquine are having lesser incidence of COVID, and even if they have, it comes out as a mild form. We have had our colleagues who tested positive with huge amount of comorbidities but went off smoothly with mild illness. In my unit, out of 19% from an intern to myself, only one tested positive, my assistant professor, and I found out he was the only person who never took it. So in my department, I have had 2% suffering, and two of them, Dr. Emil Shah, never took it, and my assistant professor never took it. So you will find majority are those who are not taking it has higher incidence. But the problem is, my colleague in pharmacology, who is doing this study, Suparna Chatterjee, he tells me that, Dada, there is a bias because those who are taking hydroxychloroquine, they are also taking equally important precautions. Whereas those who are not taking hydroxychloroquine, they are usually callous about the precautions. So that may be a confounding bias. But as I said, the anecdotal fact is the level 4, level 5 evidence is it is protecting.
We would agree, definitely would agree.
Yes, so there it is, very positive. Ivermectin, Shamor, your cause. This is approved by FDA ICMR. It does antiviral activity in vitro. First highlighted in Bangladesh. The UP government has approved the use of ivermectin as a replacement for hydroxychloroquine, and even in Australia, the Center for Digestive Disease, medical director Thomas Borody, who had some great work on the peptic ulcer disease, says the FDA and TGA approved ivermectin, and he uses regularly in a hospital, and he uses it with doxycycline and zinc. So ivermectin is one. This is one of the criteria, and I'll just add another slide onto that. The Bangladesh-based International Center for Diarrheal Disease, they're carrying out a trial on 72 infected patients in 4 hospitals, and they'll have the results by a couple of years, and they have a single dose ivermectin along with 5 doses of doxycycline, while another group will receive ivermectin alone once a day, while the third group will receive placebo for 5 days. So this is one study that is going on about ivermectin. So your take on that, Shamor?
Ivermectin, I have no experience of using it, but there are contradictions. Basically, I have gone through this literature, and basically these papers highlight the use and show the good effects. But I have been witness to a webinar by the AIMS grand rounds in COVID-19 by Dr. R.S. Guleria and his group. And in the AIMS grand rounds, he was particularly critical of ivermectin. He said the dose that is advised for ivermectin, that is 12 grams, is inadequate, and the dose should be 120 milligram to be effective. I am not sure about it, but I have encountered in these grand rounds, basically this mention. Because I don't have any experience of using ivermectin, I cannot comment on this. But if it is effective, as claimed by the authors and by the FDA and other authorities, then it will be a very good drug for mild cases.
Ditendra, any views on ivermectin?
So as I said, it's a level 3 evidence. It needs more randomized control trials and meta-analysis. But till then, if you get something, it's not doing, as Kunal said, it's not doing harm. Why not use it?
Yeah, as far as I heard that the big hospital at Tata Main Hospital has picked up a lot of ivermectin for that stuff.
AIMS is not using it. AIMS New Delhi is not using it.
I have no experience of this.
Yeah. So we move on to the next thing, accepted and practiced methods. Are we agreed on this thing? On the early phase, hydroxychloroquine plus minus azithromycin, ivermectin plus doxycycline, and favipiravir, which is now making a big wave. In the moderate phase, oxygen therapy, high flow nasal cannula, prone ventilation, steroids, remdesivir, anticoagulants, convalescent plasma therapy, and to manage the cytokine storm phase, tocilizumab. So, any comments on this before we move on to the next thing?
I'll just,
yes,
1 minute.
Yes,
regarding the early phase, most important thing in the early phase is to segregate the cases who will be kept at home under domiciliary quarantine and the patients who go to hospital. Hydroxychloroquine, as of date, basically it has been disproved. However, still AIMS is continuing it as a level 1 treatment for early phase. However, it has been disproved by articles in August. Azithromycin should never be used. That is one thing, particularly in conjunction with hydroxychloroquine for fear of arrhythmias. And regarding ivermectin and doxycycline, as I told you, I don't have any experience. At least in our country, AIMS is not following this. And most of the cases respond to isolation and supportive therapy. Favipiravir, I think, has a very limited role, and it is only important in cases, in moderate phases and in the very severe cases where drug treatment is called for.
Yes, so the rest of it, the moderate phases, the oxygen therapy, steroids, of course, that was used before the England, UK people came out with it. Remdesivir anticoagulants is a standard regime now.
Can I make a point, sir, here?
Yes, Ditendra.
Okay. Now, sir, if you look at the evidences, I mean, the poor chap, hydroxychloroquine and ivermectin doesn't have a big brother to protect them. But having said this, if you look at the evidences generated in remdesivir, evidences generated in tocilizumab, none of them have been able to test at time, because of the simple fact, in most of the circumstances, when we are trying to reduce death in moderate and severe forms, the comparison is between apples and oranges. And none of these drugs could actually reduce deaths. They could actually reduce the discharge time by 4 to 5 days. And in a mild form, nothing really matters. Whether you use this or that doesn't really matter. We are looking for a remedy in severe form. As of now, apart from steroids and other supportive treatment, HFNO and low molecular A, none of them could get through. So as I said, I'd still go on with this, as I said.
Right. That's putting it into perspective. And we go on to the next one, the oxygen therapy and ventilation. I think we are agreed on that, but I want to talk on ECMO because Kunal is here, and I will just say about the ECMO part of it. So this is basically extracorporeal membrane oxygenation, in which the blood is taken from the human beings. They say that the lung is reduced to a solid block. It is not flexible or soft anymore. It doesn't do its job of oxygen ingress and CO2 exodus. And the blood is taken to the vein. It's cleaned up. The carbon dioxide is got out. It warms the blood and puts it back into circulation. Basically a heart bypass machine. And this requires this huge team effort with at least 20 to 25 persons. And the reason why I'm going to Kunal is, from what I gathered from information, you have the highest number of ECMO treatment in India. Is that true? And can you tell us some of the experiences?
It is Indrajit. We are happy to say that we are not only India's largest experience, we are probably, as a single center, one of the larger experiences in Asia, right, at the moment. So we have in our center, I think we've done up about 26 ECMOs so far. There are currently 4 going on. We are doing a few in 1 or 2 other hospitals outside of Medica. We are helping out with Bellevue's ECMO program. So there are, I think, 1 or 2 cases happening over there. And not only Medica, I think what is more interesting is that quite a few other units of our city, like, Apollo has experience with it, AMRI has experience with it, Rabindranath Tagore has experience with it, but maybe in lower numbers. So one thing to emphasize that how we got into this ECMO business was that we were always, there were many units using it for pediatric cardiac support, cardiac assist devices. The important thing over here is, number one, is selecting the patients for ECMO. And our chaps who does the ECMO, we have Dr. Dipanjan Chatterjee, Orkod, who are the frontline commandos of this ECMO unit. You have to really select your cases at the right time. And that right time generally means that when they are markedly hypoxic and not sustaining their oxygenation on prone ventilation, that is the kind of time to go for venovenous ECMO. There has been a couple of cases where we have given arteriovenous ECMO as well. And the difference from, as you said, heart-lung machine is that the oxygenator, the average oxygenator in our heart-lung machine, lasts for about 8 to 12 hours if you really flog it long. But this ECMO oxygenator can go on for 2 weeks. So it is a more sophisticated oxygenator. So at this point of time, we have done about 26. We have managed to wean more than 40 patients on ECMO. 8 of them have gone home. And we are kind of running a salvage rate of nearly 50%. So a salvage rate of nearly 50% is really reasonably good for the ECMO statistics. Delhi has done about 7 or 8. Mumbai has done about 5 or 6. Hyderabad, there are a couple going on now. The great singer, S.P. Balasubramaniam, he's on ECMO in Chennai, MGM Hospital, as we speak. So the ECMO experience in COVID has evolved. China started off first. They had about 100 odd cases. Their results were not good because very early days, they had not really got into the protocol. Italy started doing it. The initial phase results were bad. Then they got better. UK results were good. American data has not come out yet, but I think America will report a good number of ECMOs. They have many centers capable of doing it. So there is an international ECMO registry, and we figure in it. We are going to publish our figures. And so it's been a good program. Boys have worked very hard at it. And we've now also got a BiVAD machine, which is if anybody needs biventricular cardiac support, we are able to do that as well, combine that with our transplant program. So ECMO will have a role because last one comment is because as you see, if you see something very interesting in today's hospital occupancy data, even in private hospitals, 30% of the beds are shown as being vacant. So very shortly, there will be no need for people to come into hospital for general beds. So people who will be getting into hospitals, I think both for government and private hospitals, will be people who are more critically sick. That, that buffy layer of 3 to 5% will be getting into hospital, and some of them will need this treatment. Wish us luck. We are keeping ahead with the program, and probably we will publish it in a scientific format in the very near future.
Well, that's extremely good news for the critically ill patients. We move on to the vaccines. And this is another issue. Now we have all sorts of vaccines and all that. 167 vaccine development in 27 countries. Now that's a huge figure. And in India, as our Prime Minister announced, there were 3 vaccines: the Covaxin, the Bharat Biotech ICMR NIV, one, the Zycov-D by Zydus Cadila, and the Oxford vaccine trials, which are going on, the phase 3 trials. And so far, from what we learn, it's safe and giving required immune response. So that is a good news coming for the vaccines, but they need proper trials, of course, no shortcut methods, please. The questions about vaccines. Now, the price free through government channels, otherwise we've been told it's 250 to 500 rupees, which is a great one. And who will get the vaccine is another issue. But really the 2 specific scientific things I wanted to talk to you about is viral mutation. How will the vaccines tackle that? And we've heard of this now D614G, which came out in Malaysia, which is more infective and more dangerous than what is being now here. Second is how long will this immunity last? That's a common question that is being used. And the third is the last one, the vaccine antipathy. The patients it took us a lot of years to get polio vaccine, smallpox vaccine into the human being. So these are the 3 issues: vaccine mutation, how long will immunity last, and the vaccine antipathy. Start off, Ditendra.
Yes, sir. Now, I was looking into the structure of this COVID-19. Now, if you try to compare it with the influenza vaccine, influenza virus, what you find is this is 4 times longer than influenza virus. Number 1. Number 2, the mutagenicity rate is 2 times less than the influenza virus. So what actually happens is 16 times lesser chance that the whole virus is going to change and going to create a new immune status. So even if there are smaller mutational changes, the problem 1 is they are identifying this in an NGS or next gene sequencing. What happens is that you never know whether this is a passenger mutation which is going to go off in another 1 month's time, or it's a driver mutation which is going to stay. So at this point of time, there is no evidence to suggest that general public should be very scared of the fact that there will be a huge change like flu vaccine and every year it needs to be changed. So as of now, the evidence is in favor of a stable virus, which is unlikely to be changed every year. Number 2, regarding immunity, I would suggest that the Covaxin is a whole viral killed vaccine, as like any other killed vaccine. it is going to give you a temporary immunity for 3 to 4 months unless you go on giving boosters. Whereas most of the vaccines that has come from UK, it is going to generate dual immunity. That means IgG based as well as T cell based, and therefore the immunity is going to be longer. How long? Maybe 1 to 1.5 years. The most sophisticated vaccine as of now of all the three is Moderna, because this vaccine has been created with a genetically engineered particle, spike protein, which is suspended with a nanoparticle tag within a lipid ball. So that is going to be the most expensive, at the same time most sophisticated vaccine. So looking at this, the safest it will be Covaxin, but it is not going to give us a prolonged immunity. The rest of them are going to give a prolonged immunity, but it is less safe than Covaxin. Coming to vaccine antipathy, my final take is we should be, before distribution, regarding distribution, we should not be looking into vaccine nationalism. That's the worst thing that can happen during a pandemic. Some people have money, others have infrastructure, others have production centers. It's time at least to break the social distancing and make it a global innovation, and it goes to every nook and corner of the world at this moment. Vaccine antipathy, I think, is not justified. There is no evidence to suggest it's all conspiracy. So therefore, I would not politicalize this whole pandemic, and we should all be taking vaccine, irrespective of what our belief is.
Shamor, your take on this?
I agree with him. I agree with him. Basically, the same thing. This is just like an influenza-like illness, and so the vaccination has to be a yearly process. And regarding the mutations, as he rightly pointed out, the mutations, probability of mutation, if at all, is confined to a small region, and therefore the question of mutation of the entire virus and resistance to this vaccine is unlikely. Regarding the new mRNA vaccine, as he has already pointed out, the mRNA vaccine must be an improved version, and that should give a longer duration of immunization.
Kunal, anything more to add to this?
A couple of quick points. My first point is that I think that for the I'm very optimistic about vaccines. All the very important points Diptendra and Samantha said. First thing is, for vaccines to have any kind of impact, real life impact, will probably not be before a year. To get a decent number of people vaccinated, to that have a manifestation in our movement, life and living. And for that period of time, we cannot lose our sight of the ball and get callous about the pandemic control. Because in some states and in some governmental machinery, you already see that kind of, complacency setting in, that, vaccine is in the air, Hanuman and Bishollo colony type of, syndrome is setting in, that Hanuman is flying in the sky to get the panacea down for us. So that should not happen. It does not mean, because if we lose track of the pandemic, as we tend to do now and then it can cause havoc in the interim period. Secondly is, I could not agree with Diptendra more that vaccines should not become the new Cold War missiles, because one of the geopolitical effects of the COVID-19 will be every pandemic in the world so far has had geopolitical consequences. There has been no vaccine, no pandemic without a consequence. And this consequence will be a more effective deglobalization of the world. So if we combine deglobalization with this being a biological missile by proxy, then that will be an utter disaster. And what the word of caution and skepticism is, that as the government of India is saying, rightfully, they are saying that whichever vaccine X they lay their hands on, that will get into the government distribution and the vaccinating mechanism, you see the government vaccination schedule is not doing very brilliantly even with regular normal children's vaccination. From March of this year till August, we are already 70% behind schedule with the normal childhood immunization schedules. So I think, the government machinery just cannot presume possession and control. They have to really pull their socks up and be 10 times more efficient than they have been. Because running after Corona, we've missed out on childhood vaccination big time this year already. Already we are desperately behind schedule. So this kind of lackadaisical approach because then you will be immunizing children and adults both. You're looking at immunizing God knows what percentage of your population. So that will be a huge undertaking for which we need a smarter government mechanism than what we have today. Thanks.
Now we come to this, the question of we move on to a very contentious issue, the cost of treatment. The capping of COVID treatment, the General Insurance Council is set to recommend a tariff that caps COVID-19 treatment at 9,000 a day in the metros, in the 2-tier and 3-tier cities, and 24,000 a day in metros. And can you do life-saving necessary treatment in this budget? And why do corporate hospital budget rise? I have enumerated some points, and I'll ask you to just talk about it. Kunal, you best qualified on this.
You see, to give you a brief thing, because there is something called an average revenue per day, what is considered to be to keep your nose above water for any private sector hospital. And that, Indrajitda, you see, by common consensus in a general bed level is around 24,000 rupees per day. And in a corporate hospital, by the time you've paid for your finances, salaries, etc., electricity bill, satisfied Calcutta Electric Supply Corporation, the land revenue, the State Bank of India, your outstanding finances, the local politicians, the trade unions, after every salary has been paid and every palm has been greased, then the break-even figure is around 25,000 per bed per day at the non-critical care level, and the critical care level throughout the country works out to somewhere around 50,000 rupees a day. And that costing is available with Niti Aayog, that costing is available with FICCI, that financial kind of a template is available in the country. Now what happens is, because of a knee-jerk effect there are two things happening. First of all, there is no disowning the fact that there is tremendous hardship on people. Why? Because first of all, you're getting into a financial pressurizing situation. This is the only disease you and I have seen in our lifetime where if you get into a hospital, you are having a mandatory 3 weeks hospital stay. And the entire financial paradigm has come in for a shock therapy. There is no mediclaim, there is no insurance actuary calculation, which so far has calculated a median hospital stay for thousands of patients for 20 to 25 days at a stretch. So everything has become topsy-turvy. People with whiff of a hat are getting bills of 8 lakhs, 9 lakhs, 10 lakhs at that pro rata basis, right? And even, there was not long ago, if I had a health insurance, say for a mediclaim for 5 lakhs, I would have said, okay, theek hai, acha hai, I'm more or less well provided for. But that 5 lakhs will disappear 1/3 or halfway down my treatment line, should I be unlucky to be stuck in a HDU or ITU with this COVID problem. Now, a couple of things should have happened. Number one, what has happened? If you look at the disaster that happened in Delhi and Mumbai, where by force, some government said that this 24,000, 11,000, 12,000, whatever, a disaster happened over there. There were big time hospitals which first of all, they laid off. They furloughed 50% of their staff and they said, we can't pay your salary. They asked the government to come in, a hospital with 30% staff, and said, come on, function, do what you want to do with it. So in all the major metropolitan cities where this kind of, what you call in Hindi, tu me came in with the private sector and the government, etc., which is absolutely to be deprecated. It was nonsense. It should never happen. So a couple of things need to happen. Just in the way the government has stood besides banks when they were in problem, central government needs to stand by and support Mediclaim for that 30% of population which has medical, because if you submit Mediclaim, they will deduct 30% and consider your claim. So that support needs to increase. The Health Commission yesterday came out with a recommendation of deposit, good recommendation, fair enough, we should be with people. But then there should be some like a disaster management fund, some fund which is paying at least the medical disposable expenses for private hospitals who may be treating patients for a few days who are so desperate, in a desperate situation that they cannot pay their bill. So that kind of fallback mechanism needs to be worked out. Because what is going to happen is what should not happen. And this scenario has repeated itself. This scenario, mayhem for a month, has happened in Mumbai. It has happened in Delhi. One place where it has not happened is Chennai. Because Chennai was clever from the beginning. They did not put their foot into this mess. They did have some kind of agreement. But this is no excuse for some aberrant behavior for some, private hospitals that 3 lakhs deposit and 5 lakhs deposit won't let you come into the hospital. Now that is absolute nonsense. You need to have your bottom spent for doing that. So let us have a measure of viability. I am not against rates being, a bandwidth being fixed. That will help. But mind you, these people in the commission, the people who are calculating these things, they are no fools. Why are they not doing it? Because they have got the cost templates in front of their eyes, and they know that if you really go by the realistic cost templates, it's not going to look desperately different. The main problem is you're stuck with critical care treatment for 3 weeks plus, and this financial experience, forget about the clinical experience. This financial experience has not been known in medicine for a good part of last 100 years. But there is distress amongst people. I think the insurance, the hospitals, the government needs to put our head together and work out that how we can reduce that distress on stat payment on patients at this point of time. But I just end by saying that it's not going to be very easy unless we have substantial buffering coming either from the central government or state government or both. And I had made a calculation that if the central government defined COVID as a public health disaster and supported every COVID patient in India with 2 to 3 lakhs rupees of hospital expenditure, that cost will be the cost of 2 Rafale aircrafts. So you and I need to make that decision of public conscience, that whether you want to defend a lot of sick people with sophisticated weaponry is the decision for the conscience of India to take and not for a few hospitals to decide. Thank you.
I think, Kunal, that was an impassioned appeal, but I will also go to the other side of the story, which I will ask this from Diptendra and Shamor. The behavioral aspect of what is happening. The unethical practices, there are some definitely there, and that's the reason why some hospitals are being penalized. Inflated bills, mistakes in bills. The advances. Why the advances have to be taken? Because patients are often unable to meet their dues when it comes to beyond the advances. And the other thing, insurance companies releasing payments after months or reducing payments. And it's a fact that the promotion of their personnel depends on how much they've rejected. A group of persons specialize in creating trouble in hospitals. We don't. But the major thing is the disappointment, where complications due to comorbidities of the disease itself, and this pandemic is particularly in that, the result is poor and bills have to be paid. So that is the whole aspect from the other side of the view. Diptendra, your suggestions on some of this?
I am not a wonderful expert or pundit on health economy, and I learned a lot from Kunalda. What I feel that it's a time where the government, as well as the health commission, as well as the corporate hospitals, should initiate a very constructive dialogue. It's extremely essential to have a dialogue going continuously rather than unilateral enforcement of rules and capping. And the second thing, I think it's also time that we should be talking to banks. I mean, in certain situations where the bills are going really growing very fast, I mean, banks should also come on spot loans, which can be made up. I understand it's a very expensive treatment. 3 weeks in an ITU on an ECMO can be an astronomical figure. The other side, which I feel have remained quite neglected, is the communication. I do understand that healthcare professionals are also undergoing a tremendous stress at this point of time. We are not in a mind frame which we normally are while we were doing in the pre-pandemic era. So it's important the communications has to begin properly, because a common complaint from most of the patient parties, whether it's a government or it's a private hospital, is they do not get the information about what is happening about the patient. And there are diverse informations coming from different group of peoples. Some tell it's good, other tell he is very critical. So there has to be a very well constructed thought of and planned layout of informing the people what is happening to the patient, a sort of bulletin outside the hospital every day. What is the present status of the patient? And I don't think it's very difficult to do. Rest of the things, as I said, it's a catch-22 situation, really. You can't actually come out of that because it's costly, it is expensive. At the same time, we have to save life. And the point well taken from Kunal, that it's time for the government of India to go into direct subsidy of treatment expenses in corporate hospitals. That's the way out, I think.
Yes, so that I think
Indrajit, I'll just make half a sentence. An important point is one very good audit. I'm not saying that for any kind of mutual competition. You see, the government is spending an enormous amount of money in treating COVID patients. So if you just audited and calculated the amount of money government is spending per COVID patient, you will definitely get an idea how much it costs to treat a COVID patient in a private hospital.
That's right. That's right.
Yeah.
Shamor, your views on this very debatable topic?
First of all, I feel the human factor should be there. There is a total lack of communication between the patient, family, and the hospital. That is why the patient's family are being kept in the dark, and sometimes they are not informed, and it's very difficult to track patients, particularly in government hospitals. When some patients are admitted somewhere, they cannot be followed after a few days, and after a few days, they identify the patient is in very critical state, and within, say, 1 day, that patient expires. So that leads to much mistrust and commotion and very difficult situation on either side. So communication has to be there in some form. That is, I know the hospitals are overworked, but there should be some mechanism for the hospital to communicate with the person's family. That is one thing. And regarding the bill scenario, something has to be done. Two things. Either the government must directly contribute to the treatment in some form, or the government should make a ceiling on the bills so that it is affordable. Those who can afford, something has to be linked to the income of the family or something like that, because otherwise people who require treatment will be denied treatment. That should never happen. So either the government contributes or some other arrangement is made, because there is not adequate amount of hospital beds in the government sector to treat this illness.
I think that is a dichotomy. On one hand, we have the government sector where there is no cost of treatment. On the other side, we have the corporate hospitals who are giving all the big ways and trying to save the life of a patient. And how do you make a price on the life of a patient? So the whole thing is somewhere lies in between. I'm quite sure we are all agreed on that. The government has to come in, the banks have to come in, greater communication has to be there. All of this has to come in. But on the other hand, it is also the duty of every hospital, not only the corporates, to communicate properly. To communicate properly, that's a real issue. And to take care that the billing part of it is kept logical. It cannot be an illogical billing in some way, which happens in some.
It should be transparent. It should be transparent.
It is transparent. Everyone is given a written piece of paper. And it's very difficult.
I don't think, Samartha, there is, I think for most hospitals, there are aberrant behaviors.
Yes.
There are people who do try to be mischievous. Let us not absolve ourselves of those kind of, deviant behaviors. It does happen. But, another problem that maybe some other time we can discuss it. When you talk about communications, it is not just communication about a patient. The whole fundamental practice of a doctor approaching a patient has been changed. It has shattered. So there will be a lot of germane difference how a doctor approaches a patient as we emerge from this situation. The way we address critical care. I've been within this sort of firing line of critical care for 3 decades now. I tell you, I have not seen critical care in this form. So there will be far more, there will be radical changes in how a doctor approaches a patient in critical care. This is the first time we are approaching a patient, not just as a sick person, but a sick person who can infect you.
One thing I just want to emphasize this, there has to be communication from both sides. Neither of us, either the doctors or the patients, we are having problems in communicating, particularly the patients' relatives. They're always suspicious that we are overbilling them, doing unnecessary things and other things. These things can be solved if we are more transparent, if we communicate with them regularly.
That is very true. Right now it is slightly less. About a month back, month and a half back, there used to be half the patients whose near relatives cannot, the patient is in hospital, near relative is in quarantine or possibly in some other hospital. This is another disruption. For this, you see, the system was not ready for this.
Yes. I think we will all evolve out of this. All hospitals will evolve, patients will evolve, and something is going to be happen. But absolutely on the financial front, there has to be intervention from the government, from the banks, etc. If they can loan so many people who run away with the money, why not in this? I mean, this looks illogical. And the government should look at its spending also. It's not possible to be unrealistic about the spending. And they have to realize what's where, what is necessary for the citizens of the country. So we go on to the next ones, and this is another important one which, have we forgotten the other diseases? In this whole mad way that COVID has taken us in every aspect of our lives, from newspaper headlines to television news, from all aspects, are we forgetting the influenza, the tuberculosis, the trauma, the malignancy, the other infections? And in terms of incidence, virulence and fatalities, where would you place the COVID-19? Ditendra?
Sir, if we look at the crude death rate of this country, every year 91 to 92 lakh people die. And if we look at the death that has been contributed by COVID-19 till now, it's 55,000. And if you look at in another 6 months' time, maximum it will be 1 lakh. So it is actually contributing to less than 1% death of the country. So there are reasons to believe that it is time that we put our stress equally on the other forms of treatment. Though I understand it's a pandemic, but that's not an excuse to stop chemotherapy. That's not an excuse to refuse a patient with road traffic accident because the COVID test has not been done. But the reality is we are forgetting that the death rate is contributing to less than 1% of the country's annual death. And if you look at the number of deaths that happened in Calcutta yesterday, it is only 18 patients. I am sure every day more than 18 patients would have died at SSKM hospital before the COVID-19 pandemic. So that's not a good reason to stop all the services. It's time that the healthcare professionals, the hospitals open up, looking into the auditing themselves, how they can go forward. It's a new normal way. We must find a path for that.
Shamor, your effect?
I agree, fully agree with it. So basically, this is more a contagious disease rather than a fatal disease, and attention to other problems must be given, because I have seen several persons very close to me who have been denied treatment and lost their lives because they were not tested positive, tested negative for coronavirus. So that should never happen to anyone.
Kunal?
No, I think all of us will be in consensus. Just one point, this is not humor, but this is true. That in the period of lockdown, from say the 24th of March, there was till about the end of August, there has been some sort of eyeballing of India's crude fatality rate. And simply because of the lowering of road traffic accidents and childhood diseases and infections, probably corona has on a net balance, it has saved some lives. So if you look at the death from corona and the reduction of death from other diseases, it may as well turn out that the net mortality in this period has been low. Like Sweden is talking about incremental mortality. India may eventually, in retrospect, look back at net lives saved simply because of the horrible kind of road traffic accidents, etc. we have. But the important thing is, I think with the exception, I've been talking to a lot of people. I think probably with the lone exception of SSKM hospital, across private and government sector, all other non-corona related activities, I don't know what's happening with you, Indrajit, is down to a trickle because of lack of transport. People are in a state of panic. So just we have to pray and hope for the best and emerge from this paralysis.
That's right. That's an important point also, that really the number of cases to treatment of all this has really gone down a lot. And people are teleconsulting on some of this and doing other things. But one is not happy with the treatment which is being meted out or can be meted out to these patients. So we move on to this was a statistic, the COVID-19 compares against any other killer disease. And Diptendra is so right when he says so. The COVID-19 so far is a 3.4 death rate, and a COVID-19 estimate will be a 1.10. But if you look at smallpox, MERS, Ebola, etc., what happened in their times is much, much more. So, can dead bodies spread virus? And this is a thing which has been going on for all over, and this is a common question which is going on. Start off once again with somebody. Shamor, can dead bodies spread virus?
The answer is no, absolutely. It should not spread unless there is a direct handling of the secretions. So basically, because a dead body cannot breathe and the virus cannot be transmitted by the respiratory route, so only if there is soiling of secretions, that can lead to other. So handling of the body in a envelope uh, which prevents transmission of disease, and that can be done very safely, and it should cremation or burning or other things should not be an issue.
Diptendra, your views?
It's very clear cut. Dead bodies cannot, the virus cannot live in a dead body. So that's very obvious. The science never taught us that. We were never told that HIV patients' dead body should not be handed over. I suddenly didn't understand why this atrocious rule came. Well, of course, if you look at the WHO directives, it's clear that somebody should not be kissing or making a face contact with the patient. It can be there as a fomite on the body, and if you take care of the fomite, there is no reason to believe that dead bodies is going to transmit the virus. Far more dangerous would have been if dead bodies transmit virus, then it would have been far more dangerous to handle dead bodies of HIV patients or patients with hepatitis B and patients with hepatitis C. If it doesn't happen here, then nothing should happen here. So it can be handled with care.
I think that's a very important message. And Kunal,
I think that is, just one. I think the whole misconception came from some sporadic Italian reports on after postmortems, right? So that was completely out of place. People got very panicky. Somehow it found it got into its way into some ICMR recommendations or guidelines, and then it was completely out of proportion. So I think there has to be a little bit of lobbying also to the civic authorities that they can make people's time of grievance and the time of, sort of the last rites of a patient can be made to look a little bit more civic and little bit more empathetic, because that is also very distressing at this point of time.
I think we are absolutely sure on this, and this is the most emphatic message going out from this panel today, is that dead bodies do not spread virus. There's nothing to comment about, there's nothing to comment about. Still, there's a lot of confusion elsewhere among the general public. Clear message, dead bodies do not spread virus. Epidemiologists and clinicians, that's another issue. But the thing is that clinicians were not agreeing with certain things that the epidemiologists were saying. And what they think came out was that epidemiologists depend on data. So there was which came out in 2018-19, 21 surveys in biomedical, medical, and clinical sciences from the US and Australia suggested that 2 to 14% of scientists may have fabricated or falsified data, with nearly 3/4 admitting other questionable research practices. And nobody depends on data as much as epidemiologists do. So that is why they came about with the blockchain technology, which in short is a distributed ledger system that organizes and stores data, and with its decentralized nature and without a single point of failure, it provides a permanent audit trail for data. So I think the epidemiologists are more confident of their data now than ever before. And their discrepancy with the clinicians is bound to get down. I will not talk about you on this, but come on to more important things is how important is home surface cleaning? Delivery packets, clothes, mobile, shoes, spectacles. We all know the rules of that. I would just ask you personally, what do you do? Delivery packages, clothes, mobile, shoes, spectacles. All three of you are wearing spectacles, so am I.
Yeah, all of us are, because as I said, facts are evolving. It's very early to comment what is going to, what role does fomites directly play in transmitting the disease. But as I understand, from the point of view of science, the viral load cannot be so huge that it can directly transfer or infect another person. But one has to be careful, because as I said, there is no robust data to prove or to disprove this. Till then, we should be extremely careful about handling all these things.
Shamor, anything?
Nothing to add, basically. Role of fomites has not been established as yet, but we should be careful, because although the viral load is much low, and usually the viruses do not survive on cloth or paper for long duration. So chances of transmission are much less.
Kunal, anything to add to that?
Oh, I think that's fine, absolutely.
Yeah. So delivery packets, I think, has gone out. No one really cares about it. And the delivery packet system, as what a CDC official said, is like getting an infection from a delivery packet is like lightning striking the same place twice. Clothes, mobiles, of course, we change all that. Mobiles we clean, shoes, etc. We sterilize and try to keep it away from the rooms. And spectacles, of course, merits cleaning all the time. The other one is add-ons, masks, gloves, caps, face shields. We are all aware that these have to be done, the masks, the gloves. The gloves is a bit of a problem. The caps we are wearing because most of us are pretty bald. And face shields. Face shields are now proving very effective and useful in many aspects because it covers the eyes, nose, and mouth simultaneously. And the masks, of course, we all know that persons who are actively involved in the disease process would like to wear the N95 or the other more sophisticated masks. Some are wearing two masks together, which is a sort of a homemade anti-splash mask, which they say. And the other people can wear their 3-layer cloth masks or 3-layer other masks when they are not being directly exposed to the COVID patients. I think we can all agree on that. So move on to the next one, home isolation. So we are now in a position, in a positive case, would you test after 10 days of no symptoms? I think the clear-cut thing is that no, you don't need to anymore. The last one, what would you recommend for doctors and direct COVID carriers? How do they go into home isolation every time they return home? I know many of us do, whatever way we do, but is it mandatory?
I would suggest that if you have elderly parents, it's better to not to go close to them. Maintain a distance, so a strong social distance, and if required, you should be wearing a mask. But generally speaking, if you are into what we call a biosecurity bubble, you should be very careful about guards when you are working, because we have been doing an audit at SSKM hospital and we could find that the majority of the infections came from the junior doctors, who thought they were staying back in the hostels because they don't want to get their parents infected. But what they did in the process, they went into, sort of birthday partying, they went into a group discussions, lowered their mask and started smoking in a small place, and that's how they started getting it. So it's very important to understand for doctors is that if we are to get infection, it will be not from the patient that he is sitting across me. It will be from one of my colleague whom I personally know, and I therefore would lower my guard while I am talking to him. So the surgeon's room, the coffee clubs, these are the places from where we are picking up infections, and not really from the OPD, where we would cover up with an iron mask if an opportunity is given to us.
Kunal, your view?
Oh, I think I would definitely agree with it. And like, in my surgical unit at the moment, I've got my entire anesthesia team who is directly exposed to critical care, obviously with proper protections. They are going in n number of times a day to monitor the ECMO patients, etc. So, we have to take it sort of gainfully. And we've had one infection so far, but as Diptendra said, that doctor of our surgeon from our unit, he seems to have picked up from somebody in his flat. He lives across the hospital, rather than from the unit. But in whichever way we have to be careful, we will.
Right. Amol, your take on this?
It's fine. Basically, regarding the second question, in a positive case, second test after 10 days is not recommended. And basically, it is according to the clinical progress of the disease. If the patient is okay after 10 days and febrile without paracetamol, then patient can go back to the community if it is an uncomplicated case. And secondly, because regarding the doctors, we take utmost care in the hospitals, but outside, as pointed out, social mixing, partying, and other things should be discouraged. That is one thing we should be taking care of. And in the community, there are so many people crowding the places that is leading to spread. That has to be stopped. Awareness among citizens has to be created at any cost.
Reluctance to test, because people are so afraid that they'll be isolated, especially their contacts will be isolated. Financial part of it, the ostracization, how often to test, and whole family.
If I'm allowed to tell something about this, now we formed this group called COVID Care Network along with Obijita and Dick Shankar Haldar and all of us, and we had been to different communities in the last, say, couple of months' time. And you won't believe the amount of ostracization that takes place if somebody is tested positive. I mean, I went to a place in close to Serpentine Lane, and there was one of the patient who was tested positive. And and we went on teaching them why it is important not to ostracize and that it is not going to spread by somebody standing in the window. After we have completed discussion, people came and told me that, Doc, you told me so many things, but what about the fish bone that they are throwing? Where are those fish bones? They are filled with saliva loaded with virus. They are going to contaminate the whole society, the whole product. So actually, it's not lack of awareness, it is overreading of science. People are bending science to their need, and therefore they are going into ostracization and lynching. Unfortunately, the index case in Calcutta started with somebody trying to hide his illness. And that scar of the first index case or case 0 in Calcutta has got into the minds of people, and people have started believing that this is a disease which people hide. And once you are tested positive, somebody comes and puts a bamboo stick around your building and somebody shouts that, how are you doing from outside? That itself is so traumatic that people are hiding, and therefore they are presenting late when they have got ARDS. And that's the reason of whatever small case fatality that we are having.
Shamor, your take, the reluctance to test. I know you have many people in your locality who are just refusing to test. You have to unmute yourself. You have to unmute yourself. Can't hear you.
Can you hear me now?
Yeah, go ahead.
Two things in my opinion. Number one is basically the fear of isolation and ostracization. This is very much there. That is, we have to educate people. And second is the cost of this test. And if one person tests to be positive, then so many people have to be tested. The total cost of the treatment and the ostracization, these two things are preventing people from testing when it is indicated. They are waiting for them to worsen and then they're only going in for testing. So if we can educate them and assure them, then perhaps testing can rise.
Kunal, you're facing this problem of, you have to unmute yourself.
I think the reality is that a large number of people, who are probably getting better after a few days of fever, they're just keeping themselves separate and a kind of isolation at home and working on the logic that what extra would I do if I had tested? I would just stay separate, stay in isolation, and then get better. So this is a kind of mindset which is driving a lot of people. And since, thankfully, great majority of them are in the very mild symptomatic group, they are hanging around in home with 2-3 days of fever, staying back for another week or so, and then getting back to work. Now, point remains, had they been positive, are they potential spreaders of infection? If that is so, then they are definitely doing more harm. That's the point.
Okay, another contentious issue, lockdown or no lockdown. Epidemiologists versus economists. The epidemiologists are models of transmission, so they see a steep infection curve. They will increase the social distancing, they will prevent hospitals being overwhelmed, deaths come down. So defeat the biological enemy, forget the costs. Take all steps to stop spread of COVID-19. On the economists, they have their models also. They have a measurable economic value on human life. Lockdown, economy slowing down, it's a no-no. So you have to trade off between virus-related deaths and health and human beings also. So,
Sir,
yes.
I just missed it. Was the question directed to me?
The question is that no, I directed to all of you.
Okay.
Lockdown or no lockdown, the battle between epidemiologists and economists. The economists want the lockdown to go, the epidemiologists want the lockdown to stay.
I mean, as of now, if you look at all the standard model, the best model came from the Imperial College. It is very clear that prolonged lockdown is not going to help. If your country is ready to go through the battle with its infrastructure, there is no point in keeping the whole country into lockdown. Now, if you look at what happened, if you look at the in general, there are 4 types of countries in the world, as has been classified by WHO. One, like South Korea, which had the experience of knowing how to deal with it, and the way they dealt with it was just seal their border and dealt with it. The second was countries in Europe who started late, but they went through the whole thing very fast. And the curve went up like this and went down like this. The third group of country is US, who went into a complete erratic mode. They treated the whole country not as a whole country, but treated them into 50 different states. And therefore, they are in a mess. The fourth country is countries like India, who have been very skeptical and who have taken a very, very shaky steps throughout the pandemic. And they are not going directly through the fire or walking through the fire. They are trying to go for a middle path where a certain amount of lockdown and certain amount of opening up of the whole things are what is being followed by them. So I think India is following a middle path. But as I said, if your country is prepared to deal with its health infrastructure, there is no point for a country to go for a 6 months or 8 months of prolonged to nationwide lockdown. But inter-district movements has to be stopped.
The one, I think, just one supplement, some supplementaries to what Diptendra said. Neil Ferguson, who is otherwise known as the father of lockdown, who weighed down upon Boris Johnson in a matter of 48 hours to announce the British lockdown. And he himself broke the lockdown a week into it because he was visiting his girlfriend, who happened to be a married woman, and therefore had to resign his job. Now, that apart, what has happened is, I think here Diptendra has given a very good summary, but the boldness in shutting your borders early and isolating yourself from the source of infection has been a wisdom which has been shown by Southeast Asia. You see, if you start from Taiwan and move down up to Myanmar, all these countries, if you add up the total number of mortalities, the total number of lives lost in this entire South Asian belt is probably less than 500. Okay, not all data is believable. Probably Myanmar is not believable. But the moment we reach the population intense Bangladesh and thereafter, Bangladesh, India, etc., somewhere we get lost in the confusion. And the only country, I think, of all the Western nations who took corona head on simply on the merit of their healthcare infrastructure was Germany, led by their magnificent, the critical care, and they are one of the fewest Western countries who wove their primary health into their secondary health, and therefore their mortality was so low compared to the others. And in summary, all the countries who were led by wise women have done better than the countries who were led by the alpha males. So you had Trump, who has come a cropper, Bolsonaro, who has come a cropper, Putin did not look too clever, the fellow in India, I forget his name, what he's called, he has not covered himself in glory so far. And if you compare to the rest of them, to the Angela Merkel, to the Aung San Suu Kyi's, to the Jacinta Ardern, I think the women have proven far better corona controllers than the men at the national level. Just an observation.
Howard, anything to add to it? Was the lockdown or no lockdown? Where do we?
We have emerged from the stage of lockdown, and basically, people should come to accept a new form and adapt to that. Otherwise, people will die of starvation. So, lockdown continuing further is no solution.
Correct. Our death rate is one of the lowest. And I will have to go on with this. Globally, on the 18th of August, this much of deaths. The death rate is 3.54 in the world, 3.15 in the USA, Brazil 3.54. Italy had 13.92 when it was at its peak, Sweden 6.8, UK 12.96, India 1.9. So with a less number of tests, we have low death rates. With more tests done, whatever antigen, antibody, whatever it is, there will be lower death rates. So the question is, are we under-reporting deaths?
Yes, we are.
And are we following the WHO directives that even COVID-like symptoms, though negative or non-tested, should be called COVID deaths?
Actually, regarding the last point, COVID-like illness leading to death are not being reported as COVID deaths. So that is leading to underreporting. This is one thing for certain. And secondly, there are so many people who are dying before a diagnosis is made. So in those two ways, the number of deaths is low. And third factor is basically Indian population, general age is lower. So the incidence of COVID in a young individual, usually fatality is less. All these three factors are contributing to the lowest death rate.
Right. Diptendra, your views, why is our death rate so low?
So number one is the median age of the Indian population is 29. Whereas in countries who have higher death rates, more than 10%, it would be between 60 to 70. So that's the first factor. Number two, India has picked up a viral strain, which is called, I just forgot, it's A3 something, which is relatively less fatal. So these are the 2 points. And in the West, why there was a huge number of deaths. And if you look at the death audit of the West, you will understand the major deaths were in the old age homes or the care homes. I mean, fortunately, India doesn't, at least, I know there's a point of discussion after some time, but joint families, thanks to the joint families, you will have elderly parents taken care of. If they were in old age homes, if somebody suffers, all of them will suffer. The fatality will be very high. And in the West, we have seen a whole group of care homes have been locked and people have died behind the locked bars. So that is one of the reasons that the fatality rate is so high in the West and not so much in India.
Kunal, why the death rates are so low?
A couple of observations, you see. I mean, Indians being very wise, they were planning ahead, you see. because country with the worst possible healthcare system has the lowest age group population. Because even in the non-corona times, we were eliminating our elderly people anyway. So after 73 years of freedom, if you've got a median age of 29, 30 years, it basically, one of the conclusions is that you've got a hopeless healthcare system. Kerala is the only state which has 65 plus population in double digits. Secondly is that Hindu did a recent report, and according to Hindu, I think that was a bit exaggerated, but according to Hindu's reporters, they made a comment that deaths in India, corona-related deaths, were very underreported by a factor of 5.5 or something, they said. I think that was an exaggeration. But even if you did, in terms of per million population, our fatality is 440 per million. So even if that was like 5 times higher, it would have not made a huge impact in the global scale. And if you look at death reporting in India in non-corona times, about 80% of deaths, they say, gets reported countrywide, and 25% of them in any way have a valid medical certificate. Right. So I think some of the data will emerge later on when we try to comply, when we try to countermatch that how many deaths were actually reported and how many death certificates were there, maybe. But even if you count for all those figures, I think the fact that we've had a hopeless healthcare system which counted for a young population and thereby in the corona times reduced our mortality. So you see, every bad work has a good purpose.
Well, that's a conclusion which I'm sure the planners didn't have in mind. But whatever this is, this 1.91, and we are all the time harping this figure, and look, our death rate is so slow, so low. There could be valid reasons, but one of the things which is not, which Kunal has said, we are underreporting deaths. So that's another issue which is contentious. The WHO role, I'll just go over the slides very quickly because we are running out of time. The WHO role, the January 14 preliminary investigations conducted by the Chinese authorities found no clear evidence of human-to-human transmission of the novel coronavirus. The same day, the Wuhan Health Commission's public bulletin declared, we have not found proof of human-to-human transmission. And then Li Wenling was for spreading rumors. Now he is a martyr after he died at the age of 33 of the virus itself. And the executive director of the WHO's Health Emergencies Program said, there's an understandable confusion that occurs at the beginning of an epidemic. So we need to be careful, misunderstanding and misinformation. And together with that, then the WHO went on. The countries find reasons not to be transparent. It's difficult to know what we can do about it because the countries, all the WHO depends on data coming from its member countries. So one study found that China could have limited its own infections by up to 95% had the government acted in that early period where doctors raised the alarm and the Chinese Communist Party was denying the extent of the problem. The WHO at that time didn't do their job, and they actually compounded the Chinese authorities with the misinformation for a few weeks, which was unforgivable. So the recommendation on masks, and really that was something which June 8th, only as late as June 8th, the World Health Organization changed its stand on wearing face masks during the pandemic. People over 60 and people with underlying medical conditions should wear a medical grade mask when they're in public and cannot socially distance, the WHO said. And the general public should wear a 3-layer fabric mask in those situations. And they updated their advice for medical workers, saying all of them should always wear a medical mask while in clinical areas, not just people working with COVID-19. And they had previously stated that there wasn't enough medical evidence to support members of the public wearing a mask until they were sick or around people with coronavirus. So all this the WHO did. And as Kunal said, the WHO's role in spreading the pandemic. More, as Kunal expressed, the lost early weeks That went on with the Chinese New Year. People wished to, millions of people traveled, millions of Wuhan people were misinformed, and then they traveled all over China and then all over the world. So Chinese official confirmed publicly for the first time on January 20 that the virus could indeed spread among humans, January 20. And within days after that, they locked down Wuhan, but by then it was too late. It took another week, January 27, for the WHO to declare the spread of the virus a global health emergency. And Tedros Adhanom Ghebreyesus, the WHO's Director General, visited China and praised the country's leadership as setting a new standard for outbreak response. Another month and a half went by before the WHO called the COVID a pandemic, at which point the virus had killed more than 4,000 people and infected 118,000 people across nearly every continent. The WHO's role in the pandemic, Kunal, I know you have the most thing to done.
No, I think you really made a very good summary of the fact, and the WHO obviously has not covered itself in glory. It is wrong to be personal at this stage, but Tedros, when he was appointed the Director General or whatever of WHO, even that was under very contentious circumstances, because during Ebola, etc., there were 2 or 3 other instances in Ethiopia and in the larger African context, where Tedros was known as his critics as the expert of epidemic suppression. So I don't know whether intentionally or accidentally he displayed his skills on this occasion. But they definitely have a lot to answer for. They got themselves in a twist. And more importantly, Indrajitda, is that another part of this puzzle is Taiwan. Because Taiwan, being 130 kilometers from the mainland of China, Taiwan shut its borders to China in November, right? Because they obviously got to hear, they can hear footsteps from China. So they got to hear in late November that something funny was happening over there. Taiwan shut its border in November, and there were umpteen communications from Taiwan to WHO, which they completely ignored, and the rest is history. And Taiwan, for that matter, because they want to curry favor with the Chinese, Taiwan is not even considered to be a legitimate member of the World Health Organization. So I think, there will be a lot of dissection over there. There will be a lot of breastfeeding, and most probably WHO will not survive the pandemic in its current form. It is going to be melted down and recast. And God save them, on 26th of November, if Donald Trump gets re-elected, they're in for some music.
Diptendra, whose role?
Apart from what Kunalda has already told, one of the things I thought the worst sufferer of infodemic has been WHO himself. I mean, they have been arguing that one should not go for infodemic and they should not go into trash informations. But it was WHO that every new article that came up in Lancet, and they would come up and give a statement next day morning. You cannot change your stance every day morning because of a new publication that has come up in a journal. That's not done. I mean, you should wait for robust evidence to come up and then consult your experts and come up with a statement. Statements in mass, statements with hydroxychloroquine, the way they change their stance every day based on the new information, at times to say in a lighter mood, they believe more on WhatsApp than on published article.
Shawar, your views?
I agree. Basically, WHO's responsible has a lot to be desired. Basically, it is the handling of the situation that landed us in this catastrophe.
Yes, absolutely. I would agree with you. I think the panel agrees on this, whose role has not been admirable at all. Would we have done better? Could we have done better? Now, there were haphazard travel restrictions and double standards. The January 17th, the travel advisories for those going to China. January 31, 25 countries had COVID cases. They were not banned. March the 3rd, banning entry from Italy, Iran, South Korea, Japan. No ban on USA. We did 87. France had 212 cases, Spain 166, no ban on them. March 22, 150 countries with 292,142 cases. And India suspends then on March 22 all international travel. No figures for migrant workers, millions stranded, long walks home when we really know all about that. Further problems, the migrant workers were crowded into trains, sent back without proper testing, only a thermoscan. Sent back in buses, lorries without proper testing, only thermoscan. And the Vande Bharat mission started bringing back without testing at source, only thermoscanning at destinations, persons giving wrong addresses, many were untraceable. Domestic flights initially were untested. Even now, there is no social distancing in many planes and relying on self-quarantine unchecked. So shortage of emergency supplies, red tapeism. The PPE exports were banned from January 31, but raw material export was allowed. So much so that the PPE Manufacturers Association said India lost around 5 weeks in the production capacity of PPEs. If we could have been provided the specifications and the basic numbers of stockpiling, we could have set targets. In place of the 38 million masks and 6.2 million coveralls that were required in India, only 9.1 million masks and only 8 lakh coveralls were available initially. We have now recovered dramatically, but that is the Indian resilience. It was only in March 19 that the center stopped ventilator exports and initiated moves to procure them. Yet another week passed before the government banned the export of ventilator components and other respiratory apparatus. By then, India had reported a total of 519 COVID cases. And that's not all. The shortage of testing kits and delay in domestic productions. So ICMR guidelines on domestic testing kits issued on March 23 included an inexplicable condition that required domestic testing kits to be approved by the US FDA. Domestic manufacturers had already submitted to the National Institute of Virology, Pune, but now they had to undergo this thing. And coupled on that, low testing rates. We did not test more, we did not test quickly, we did not test properly, and we had bad kits supplied to us, which we all know about. So ICMR was assuring the public that community transmission of COVID-19 was not yet detected in India. Hospitals were turning away patients with COVID-19-like symptoms simply because ICMR's then guidelines offered no provisions to test them. And what Michael Ryan said, that speed trumps perfection. The problem we have at the moment is that everyone is afraid of making a mistake. Everyone is afraid of the consequences of error. But the greatest error is not to move. And we did not. So with all this, satisfied with our responses, Kunal, are you satisfied with our responses? Can you hear me?
Arranging somebody's hospital admission.
Yeah.
Yeah, sorry. What was your question?
Are you satisfied with our response that we could?
Well, I think there's no point crying over spilled milk, but perhaps we needed to be epidemiologically sharper. And where I think, we lacked a little bit of coordination is we promulgated the Pandemic Act, the Disaster Management Act, everything. The first 2 months, it looked like it was a central government sort of a symphony orchestra led by the central government. And when I think after that, it looked as if that, things were not going according to script in terms of numbers. Somebody had some different expectations that we will come out of it in a very lukewarm kind of way. But I think that was an unrealistic expectation. That was not to be. And when the going was not good, suddenly it fragmented from being an ICMR or a central government-led operation to India suddenly became a very disjointed, sort of uncoordinated federal entity of 30 states. So for 30 states had 32 different versions of this mitigation policies. And honestly, it looked a bit comical and looked a bit sad at the end of the day. But given all that, Indrajita, I think the point in question remains, that with our population density, perhaps if you look at the current numbers, then epidemiologists will tell us that it is, so far, it's not that bad going. Calcutta today has reported some 550 cases with 8 deaths. So I think some of it is perhaps true, if not all of it. So even if we can get by in this sort of lumpy, bumpy roller coaster, right? And another, just to, at the end of it, I think one thing hurt us, that unlike an Anthony Fauci or a Neil Ferguson, it was very painful that in an era when 15 out of 20 leading epidemiologists in the world were Indians, India did not identify its own core group of the epidemiological intelligentsia who led us in this campaign. We saw, all kind of ministers, we saw pediatricians, cardiologists, biomedical experts, but why were we so shy, and why were we so hesitant to display that this is the think tank, this is the commander-in-chief of our epidemiological unit? That escapes me. You go through any international conversation today, 15 out of 20 epidemiologists are Indians all over the world. So water everywhere, not a drop to drink, as far as we were concerned. But given the population density, even if we swim through these waters, perhaps it won't be that bad.
Yes. Shamor, anything to add to that?
No, thank you.
Yes. So we'll quickly go on to we are entering the nearest of the thing. Sorry. The R factor has come about. The R factor refers to the effective reproduction number. The R factor signifies the average number of people that one infected person will pass the virus to, and you'll hear a lot more about the R factor. So keep the R factor below 1, infections will lessen. Lesser the number, the quicker the end. Initially, R0 is a new virus of no immunity. So China started off with 2.2 to 2.5, increased to 6 to 6.5. A flu has an R factor of 1.3, measles at 12 to 18, but vaccine is improving, as was present to control measles. We don't have a vaccine for this as yet. Lockdown has eased, the R jumps, so we get a second wave, and the R low, then we go to contact tracing location apps starting. I'll just give you some figures on this. The Tamil Nadu last week had an R factor of 0.92, they've gone up to 1.03. Bengal had 1.14 last week, it's down to 1.06. And Kunal, your figures reflected in this R factor. It was 1.06 last week, it's 0.92 in Kolkata this week. Maharashtra 1.12 to 1.10, and Uttar Pradesh 1.27 to 1.06, all of which goes that we are going the right way in this as has happened. And final question, do you support the holding of the NEET and GE exams in this format? Kunal?
Well, I think you have mixed feelings, but if they could, I think holding these exams, I'm not really quite up to date with the timetable, but if the timetable is somewhere around November, then probably that's a possibility.
It's in September. It's in September.
September, I would hesitate. I would hesitate in September.
Shamor, your views?
Yes, we are actually in the peaking phase, and it will peak in August, September, and then stay stationary in October. So by November, it should start abating. And so November, December is the ideal time to hold the exams.
Right. Diptendra, I think, is not on. Diptendra, are you on? I can't see your picture. So, so we have the joint families as our home turned into a hospital. I think that's a logical, what is happening. India has a number of joint families, but that's not an ideal situation in this situation, in this pandemic. And the super spreaders that were there. So controversies will stay, so will we. So we must know it is our lives and lives of our loved ones as we battle the greatest threat to humanity, which we have to win. And I'll conclude this with this final slide. So thank you all the panelists, all those people who stayed here. Kunal, thank you so much for taking up. I knew you must be very tired of these 2 consecutive webinars on a Sunday. Shamor, thank you very much. I know you're embarrassed by me thanking you, but there, that is it. Deeptendra, thank you very much. And to all the audience and who was so patient enough to stay with us for 2.5 hours. I think this has been a most illuminating discussion. We learned.
Indrajit, if I may just say a word that, you know, I've probably been into many talks and discussion, but the painstaking planning with which you've executed it, I know it's gone on for more than 2.5 hours, but I think it's been very educative, very thought-provoking for all of us. And thanks for asking, and really appreciate the pain and the research you've taken behind this event. It was so gratifying to be a part of it. Thank you.
Thank you, Kunal. Shamor, thank you so much.
Thank you so much.
And let's sign off for now and hope we take up some good things from this right away. Not only us, but all the people who listen to us. And then when we edit it and put it out on the YouTube for others who will log in and see also. Thank you. Thank you so much.
Thank you.
Pleasure.
Good night.
Good night. God bless.